All right, guys. This is sorry, I skipped the title slides. Cholesterol and thyroid slide or lectures. Hypothyroidism is basically a slowing of metabolic processes, and you can see the different side effects here that are caused by that. It affects a number of things, and it has to do with the hypothalamus, the pituitary, and the thyroid gland all working together. There's a couple of different hormones. The ones we're most importantly thinking about are thyroid stimulating hormone, or TSH, which when released from the pituitary gland causes the release of T3 and T4, which are thyroid hormones, T3 being the most active form. And what happens is that when we're monitoring for hypothyroid, TSH levels get really high if somebody has hypothyroid because if their thyroid gland isn't properly releasing T3 and T4, you get these positive feedback loops that will say, hey, we need to upregulate production of TSH, and then you end up with really high TSH levels and low T4 levels. And this is showing basically the same thing with respect to dietary iodine intake. Iodine is a big component of thyroid health. And so our salt and stuff iodine's pretty ubiquitous in the Western diet, so it's not usually a big deal of getting enough dietary intake. Usually hypothyroidism is a permanent lifelong condition, much more common in women than men, more common in older women, but still prevalent maybe in younger populations as well. Therapy is pretty straightforward. You just replace the missing hormone and the symptoms will resolve. We replace it using an oral T4 supplement. And again, we're looking at TSH, and that's going to be high in a hypothyroid patient. Here's some factors that might cause increased requirements, pregnancy being one of them. Levothyroxine is the drug here, and it's synthetic T4. There's a couple brand names, Synthroid and Levoxyl. There's some controversy about switching between brand names and generic names, and the reason is because thyroid dosing can be a little bit sensitive, and so if you switch from Synthroid, say you're taking 100 micrograms of Synthroid, and your insurance says now you need to be on Levoxyl. Well, I switched to 100 micrograms of Levoxyl. Maybe the Levoxyl is actually 105 micrograms because to be within specific to meet specific criteria for the FDA, a drug can have a bit of variance there. So 100 micrograms might be 105 with some brands. Maybe it's 95. So let's say it's 95 with Synthroid in actuality, but it's 105 with Levoxyl. That's a 10 microgram difference per day. Could end up being enough to make a difference. Usually it doesn't matter, but it's really best to stick to one brand. So you may have patients who say, well, I've always been on Synthroid, I need to be on Synthroid. It's not that they're being weird and making you prescribe a generic. It is maybe more indicated in these, or make you prescribe a brand name product. It's not usually because of that. It's more because of the variability with different products, potentially. So it's well absorbed throughout the GI tract. The T4 is converted to active T3. The nice thing is that your body can have circulating T4 and convert up to T3 when it needs it. And so that's why the drug is usually fairly effective. If you give enough T4, you can end up with a higher conversion rate and end up with side effects. But normally it's difficult to get really toxic on this unless you're really aggressively dosing somebody inappropriately. Half-life's quite long, so that's also nice for this medication. It's really common. It's actually the most commonly prescribed medication in the United States. There's some debate over whether it's levothyroxine or some sort of hydrocodone product like Norco or Vicodin, but most studies that I've read recently show that levothyroxine is the most commonly prescribed medication in the United States. It is okay in both pregnancy and lactation as well. Levothyroxine comes in different colors. The colors correspond to different doses. So for example, if you have a Synthroid 150 that's this color, it will be the same color in Levoxyl. So we can actually go back and see this Levoxyl is 88. If we look at, well, actually that doesn't make sense. So that should be green. So maybe the color is wrong here. Sorry, it's not a good example. The point is that the color should match with the different brands. So if they're like, I'm taking the yellow Levoxyl, it should be the same as the yellow Synthroid as far as dose, but most of the time it doesn't really matter. Dosing is usually started based on weight, but that's the ultimate dose you want to get to. So you might have a goal dose that's 1.6 mic per kg per day, like it says here, but usually you're going to start people on 25 or something like that, something relatively low. Increase them up slowly to that goal dose and just monitor the labs and see what happens. Usually we're looking at lean body mass too, and dosing it based off of that. So that's also important if you have an obese patient. Take on an empty stomach before breakfast. You probably see that's when it's best absorbed. Usually 2 weeks is when you're going to see improvement. It may take several months though. If somebody isn't improving, increase the dose. If they still aren't improving, keep increasing it until you start to see some side effects. And then you can try a different strategy. Sorry, let me get rid of this thing. It's kind of annoying. Okay, there we go. Levothyroxine. Again, the maintenance dose is something that you are going to build up to, and then you're going to check labs about yearly. Could change based on a variety of factors, like on slide 6. Very effective therapy. Side effects are minimal except for if you overdo it. Then you're going to see some hyperthyroid symptoms, which we're going to talk about in a few slides. Their drug here is liothyronine, or Cytomel. It's synthetic T3. Generally, we don't use it because it's basically like giving somebody a burst of thyroid hormone that's active and immediately used. T4 is nice because it has to go through a conversion process, so it's not quite as fast of a fluctuation between the active medication being used and also off. T3 doesn't have a very long half-life. It's used quickly. It's very difficult to replicate physiologic levels. Even if you try and mix T4 and T3, clinically what's been shown to be best is just to use T4. If you have patients who are using T4, have difficulty getting labs to where you want them to be, you may need to add a T3 on as a combination, but it would only be for those patients who are struggling with the standard therapy. Excuse me, yawn. I should say that sometimes they do use T3 in depression. So patients who are hypothyroid may be at risk for depression, and they may treat depression with a component, thinking of the pathophysiology having a component of hypothyroidism and using liothyronine for that. Armour Thyroid's an old product. It's rarely used anymore. Patients who have been on it for years and years might still be taking it. For the most part, we don't start anyone on it. Some people may seek it out thinking it's a quote-unquote natural product because it is desiccated cow and pig thyroid. Personally, it ends up kind of working out to being some combination of T4 and T3. It's no more effective than regular T4. I would personally just go with T4 because it's probably going to be the most clinically studied version of what we have. Armour Thyroid may be less expensive in some instances, but it actually isn't very cheap just due to the processing involved with it. So again, you may see this out there, but I don't put much stock in it personally. So basically the treatment's really easy. You do your T4 product, you add the T3 if you aren't responding, and that's pretty much it. So if you happen to overdo it and end up with hyperthyroidism, it's the opposite side effects. So really thinking of increase in metabolic things. And the big one here is going to be, big group I should say, are hemodynamic effects and cardiac effects. So blood pressure and tachycardia. Here's a comparison in case you're curious. Sorry for the weird picture. I don't know who that lady is. Causes of hyperthyroid. So the way that they check hyperthyroid is they can do a radioiodine test. So they're looking at how much iodine they give radioactive iodine intravenously and see how much the thyroid gland is taking up. If it's normal or a high amount of radioiodine, they think about it as an autoimmune disease, some sort of tissue disease, which could be an adenoma or pituitary tumor. If there is very low or absent radioiodine take, it could just be that there's some sort of toxicity or inflammation of the thyroid gland. Amiodarone, we talked about that in the antiarrhythmics, that can cause that. Also radiation can, or excessive replacement therapy can cause that. Graves' disease is the most common cause. It's antibodies the body creates against the TSH receptor. Ultimately, what happens is you end up with a hyperactive thyroid. And you get those systemic side effects like I was talking about. So oftentimes the common treatment for these side effects is beta blocker therapy. Beta blocker therapies are usually a band-aid, if you want to think about it that way. They're going to help treat the symptoms and buy you some time until your corrective therapy can give it. Thianamides, we're going to talk about on the next slide. Those are our corrective therapy. And then you also have radioiodine therapy and surgery ultimately as your kind of end game items for what you're going to have to do to really address the problem ultimately. So if somebody's going down the road of hyperactive thyroid Graves' disease, it'll take a while for them to get to the point where they need substantial therapy. Usually you can be managed with a beta blocker as a supplement for a while and be okay with that. Ultimately, you get to the point where you have a problem that can't be solved with those symptom mitigating agents like beta blockers anymore. So you have to go with something more direct, targeted towards helping, basically inhibiting the thyroid's function. So the goal is to attain a euthyroid state in about 3 to 8 weeks. And so that's what these drugs come into play. And then you can do some sort of ablative therapy, whether you're doing radiologic therapy or surgical therapy. So what happens is there's two drugs here. There's methimazole and propylthiouracil. And they inhibit synthesis of thyroid hormone by blocking the oxidation of iodine in the thyroid gland itself. Therefore, you can't create T3 or T4. It also does not inactivate T3 or T4. So your circulating T3 or T4 is still going to be available for use in the body. It's just going to prevent the production of new T3 or T4. Methimazole is the common drug here. However, for your patient population, mostly being pregnant women, propylthiouracil would be the drug of choice here. It is okay to use in pregnancy. The side effects really are going to range be all over the place. Methimazole is teratogenic. However, again, propylthiouracil is fine. You can see some side effects here that I'm not going to go through very much detail. Iodine therapy can also be used. It's going to block release of T3 and T4 from the thyroid gland within hours of administration. This was sort of the mainstay of therapy for hyperactive thyroid, but it has a short-term amount of effect. Usually after 10 days of treatment, it's not really going to be much more effective. Thienamides have replaced it basically, but this is still a good short-term drug to give. Now, it's really important to start something before iodine. So you want to start methimazole or propylthiouracil about 2 to 3 hours before. The reason is because if you don't do that, the iodine could just be used by the body to make more T3 and T4, and then you're contributing to the problem. So iodine is helpful because it blocks that release, but you want to stop the production before you block the release. Hopefully that makes sense. Thyroid storm is rare, but it is life-threatening. Basically, the hyperthyroid is long-standing untreated. You can get it precipitated by an acute event too, so surgery, trauma, infection, acute iodine load, labor can cause thyroid storm as well. What happens is your hyperthyroid symptoms are all amped up. So really, again, what we're most concerned about, you can ignore most of the stuff on that slide. What we're really concerned about is tachycardia, hypertension. So those cardiac side effects that could potentially lead to a cardiac arrest or heart failure or, cardiogenic shock. Treatment, IV beta blockers, and then propylthiouracil every 4 hours. Iodine solution, remember we're going to give our PTU first and then start giving iodine. You can add iodine solution to an IV. You can also give it PO. Glucocorticoids also, corticosteroids like prednisone orally, or IV you'd give methylprednisolone or dexamethasone. They were going to reduce T4 to T3 conversion. And then once the patient's stabilized, methimazole would be started. Now, if they're pregnant still, you'd go with propylthiouracil, but methimazole generally. So that's all I'm going to talk about with thyroid, and we're going to move on to cholesterol here. So cholesterol is a very common problem in our society, as probably many of you know, high cholesterol. And really what happens is the process of atherosclerosis is involving cholesterol deposits within the arterial walls. I think some people tend to think of this as that cholesterol actually gets in the lumen itself and kind of builds up on the lining. That's not really the case. More so as you get these plaques that build up in between the tissue. And ultimately what happens is the plaque will, first of all, it'll narrow the artery so you aren't getting as good blood flow. But what causes a heart attack is when this plaque bursts through here, and then you get platelets aggregating to that site, blood cells aggregating, and you get a clot, which causes either total occlusion or that clot breaks off and then moves to a smaller part of the vasculature and causes a problem there. So it can cause problems in the heart, can cause problems in the brain, being stroke or MI being the most severe. Leading cause of death in most Western countries, and a lot of patients are going to be treated for this. Now, this is mostly a disease associated with older patients, middle-aged to older patients, but you could see it in younger patients as well. So cholesterol basics, You have low density lipoprotein, high density lipoprotein. So when we're measuring cholesterol, quote unquote, we're measuring the proteins that transport cholesterol, not cholesterol itself. So when we're looking at the two major ones, low density lipoprotein brings cholesterol from the liver to the cells. High density lipoprotein scavenges cholesterol and brings it back to the liver. Generally speaking, you don't want really high levels of LDL and you don't want really low levels of HDL. You want higher HDL has been associated with lower risks of heart disease, and low density LDL has been one of the largest biomarkers we've been using for years to associate with heart disease and to justify cholesterol therapy like statins. Triglycerides would be the other medication, or another one that's monitored. Those are fats made by the body. They usually go hand in hand with high LDL and high glucose in diabetic patients. I'm going to skip this more advanced cholesterol review. You can review some of these points if you're interested. This diagram kind of shows how everything all works together, but it's pretty much the HDL and LDL focus is what I'd care most about. So when we're targeting LDL, there's no real goal specific anymore. The newest guidelines don't have goals. So I put goals with a question mark here. But these were the old goals and what we think generally still applies. So if you're below 190, you're thought to be okay. If you're below 100, that would be ideal. If you're above 190, that's when we start to get concerned. So LDL goals have kind of gone out the window. These were some old guidelines based on what kind of risk factors you'd have. And this was the ATP3 guidelines that came out a while ago. But again, these have fallen out of favor. To 2013 CHEST guidelines came out. And they had some problems with the ATP3 guidelines and said, really, these aggressive LDL goals have never been validated in clinical trials. So we don't know if they're really worth pursuing. And let's shift away from the numbers and focus just on stroke and heart disease risk. So we're going to focus on what we know works. So we know that giving people medications to lower their cholesterol, specifically statins, tend to have really good effects regardless of what it's doing to their cholesterol. So we know that if you have really high cholesterol, it probably puts you at risk for atherosclerosis. But some people who may not have high cholesterol but have previous cardiovascular disease, heart attack, stroke, or related conditions, diabetic patients, or anyone with a general higher risk for stroke, which we can calculate. I think I mentioned in one of the cardiac lectures about the omnibus risk calculator, which you can Google and take you to the heart website. And it's going to look at things like smoking, cholesterol, BMI, I think is included, maybe not. Blood pressure is included, age. Anyway, it's going to calculate your risk of having a heart attack or stroke or developing cardiovascular disease within the next 10 years. If your risk is high, they recommend taking a statin. So really the new guidelines are all about statins. And statins are the mainstay. They've been studied very extensively. All types of statins have been all over the world, and there's a ton of evidence supporting them. So one of the big controversies here, probably doesn't really apply a lot to you guys, but something just to think about, it's sort of interesting, is that the new CHEST guidelines recommend that a lot of people take statins who previously wouldn't be on them because of this bolded bullet point here. So if you go to the omnibus risk calculator and type in like a 70-year-old patient who has relatively normal lab values, it's going to calculate a high enough stroke or heart attack risk that's going to recommend a statin. So the big question is, well, if I have a healthy 70-year-old patient who doesn't have any risk factors, why would I give them a statin just because some calculator told me to based on their age, essentially? It's an interesting debate that's been going back and forth. And here's that risk calculator in case you're curious. Okay, so what are statins? They're HMG-CoA reductase inhibitors. They are the primary drug used for cholesterol. Now, interestingly enough, the mechanism is not totally well understood. So yes, we know they lower LDL, and we know why. They inhibit this enzyme called HMG-CoA reductase, which is sort of the liver's rate-limiting step when it comes to cholesterol biosynthesis. However, the benefits are seen quite early in statin therapy. So usually people are seeing benefits in as little as 6 months. However, interestingly enough, it clinically you can't get regression of atherosclerosis in that little of time period. So meaning that once you start a statin, it's not like it's decreasing the plaque size. Somehow it's preventing some sort of an event from happening. Now, how that's happening is questionable. What we think is occurring is there's some sort of anti-inflammatory benefit to statins, and they have some sort of plaque stabilization mechanism. How that happens, again, we don't really fully know how statins are working. What we do know is that the evidence is overwhelming that they make a huge impact on morbidity and mortality when it comes to cardiovascular and neurologic disease with strokes. Cholesterol statins synthesis, here's the mechanism in more detail in case you're curious. Efficacy. So again, most potent drug, they have some, I shouldn't say decent HDL increases as well. It's small. Decent is probably a bad word. I'll say small HDL increases. Varying potency and side effects with diminishing returns, meaning that you get the biggest bang for your buck when you give somebody an initial dose of a statin. Once you increase the dose off of that, you don't generally get a ton more benefit from that. Statins are not a supplement for having a really bad diet. I think that's one of the common mentalities maybe in American culture, that you can, eat whatever you want just because you're on a statin. Great. Remember, statins and cholesterol, while that's what they're doing a lot more than that. So it's not just cholesterol that's contributing to people's disease, and statins aren't just working on cholesterol either. Just some studies I wanted to throw out there with some looking at baseline LDL reduction percentages, reduction in coronary events. You can see the pretty substantial reductions in coronary events across all these trials, and pretty large trials. Number needed to treats are good data with statins. I mean, when you're talking about evidence-based medicine, if you don't buy into statins, I don't know what you buy into, because the evidence is really overwhelming that they're incredibly effective. Now, I will preface that by saying that they aren't effective for everyone, and not everyone needs to be on a statin. But if you do meet criteria like we've been discussing, the evidence is in your favor to take a statin. And I just wanted to put a couple other trials here just for fun. The Jupiter trial, interestingly enough, targeted people with a CRP or C-reactive protein greater than 2. And it looked at people on a statin called rosuvastatin or Crestor versus placebo. It didn't look at LDL at all. And what it did was it said, okay, if you have this baseline C-reactive protein, C-reactive protein is generally a mark of inflammation in the body. And if you have a baseline elevated of that, we're going to put you on a statin, and we're going to randomize you to statin versus placebo, and we're not even going to look at your cholesterol. And what happened is that they reduced all-cause mortality and cardiovascular event reduction, regardless of what their LDL ended up being. So this was a major trial that showed that statins do more than cholesterol lowering, like we've already talked about. Prove It trial looked at high-dose atorvastatin, which is Lipitor, post-ACS, and compared that with standard pravastatin. It saw a 16% reduction in major cardiovascular events. It's another big trial that changed how we practice using statins. And because of this, the new guidelines recommend anyone after a major CV event automatically goes to a high-dose, high-potency statin. You don't start with these low potency, you don't start with low doses, you just go to high dose right away because of this reduction in recurrent events. All right, here are all the statins and comparisons. I'm not going to go through all this, but it's here for your reference. All the brand names are here. You guys have probably heard of a few of these, Crestor and Lipitor probably being the most common. Some of the other ones floating around in there too. This is just funny advertisement here. This Lescol is a generic of fluvastatin, or brand name of fluvastatin, and this was, I think, an Italian ad maybe, where they showed these people obviously indulging in various meals and stuff, and like you can the message being that you can eat whatever you want and still take a statin, which of course is not true, and I believe they made them pull this ad personally, but kind of interesting. Oh, wrong way. As far as high potency statins, what we're looking at here are usually these two drugs being high potency, with simvastatin kind of being in the middle, considered to be a high to moderate potency statin. Pitavastatin, this black or blue X over here, I would probably put in the same category maybe as simvastatin. It's kind of a high moderate potency. But Crestor and Lipitor at their highest doses really are the most potent statins we have on the market. Crestor being heads and shoulders above the other ones. In fact, even low-dose Crestor or mid-dose Crestor is better, if not similar, to high-dose Lipitor in some cases. So that's just kind of interesting to look at. Statin safety. Statins are the most prescribed drugs in the world. They have a great safety record. There's two major things to think about, and I guess a third for you. Hepatic dysfunction, very rare that we're going to see problems with this. Sometimes you see some transient ALT increases. Mostly it's not a problem. And in fact, severe liver injury is so rare on statins, it's the same rate as the general population who don't take statins. So not something we consider, but something we still get baseline labs on and would monitor for if we needed it. They are category X in pregnancy. So if you have a patient coming in who's on a statin for some reason, it will have to be held during their pregnancy. Now, that's just a risk-benefit thing. We don't want them on the statin, and hopefully statins have decent benefits that if they've been on it for a while and they stop it during pregnancy, it might still have enough benefit for what it's given them that they can start it up again. Maybe not lose much efficacy with it, but that's difficult to predict, of course. Memory loss is another one that's kind of come up. This isn't proven, but some people think that certain statins cause memory loss. There's been some evidence to support this. So actually, go back to this chart for a while. Solubility, we have most of these are lipophilic, with the exception of pravastatin and rosuvastatin being hydrophilic. It's thought that the more lipophilic statins get into the central nervous system, and if they do cause memory loss, that's because of that. So if you do have maybe, I've had conversations with people about, well, if you have a younger patient, would it make sense to maybe do a hydrophilic statin? I think so, just because you don't want to necessarily risk giving somebody a drug for 30 years and then having it cause memory problems. Myalgia is the biggest side effect of statins. Muscle pain is the biggest complaint, 2 to 11% incidence. First, you want to rule out if there's another cause. You can measure creatinine kinase and see if it's elevated. Pravastatin and fluvastatin are low potency statins and are thought to have the lowest risk, but sometimes it's thought to be dose related too. So if you have a patient on a high dose statin, maybe pull back the dose a little bit and see if that helps. Drug interactions, mostly CYP metabolized, so they are prone to competition with other drugs. And rhabdomyolysis and renal failure would be the biggest complications with severe muscle pain with statins. So if you ended up going into rhabdo, that could lead to renal failure. Managing myopathy, you hold the statin, wait till everything returns to baseline, try a new statin or reduce your dose. Check for drug-drug interactions, correct hypothyroidism and vitamin D deficiency. They've looked at a lot of things that can contribute to statin-induced myopathy, and those two have been consistently seen as the biggest contributors. Coenzyme Q10 is another kind of interesting one. The ubiquinone, which is coenzyme Q10 in the body, is endogenously produced, and it has a role in muscle cell energy production. Statins may decrease coenzyme Q10 production within the body. However, so it's been theorized that that could be a pathway towards causing myopathy. However, supplementation with oral CoQ10, like you'd get at a drugstore, hasn't been shown to be helpful. So we don't really know for sure if that's a logical, plausible, I guess, reason for myopathy or not. Okay, so who needs a statin? The guidelines are guidelines, not absolute law. So some patients may be resistant, so want to try a healthy lifestyle versus diet and exercise. I think it's important to know that that can help, and it can definitely help the cholesterol levels. But again, statins don't just do that. So it's important to know statins have proven benefits. Diet and exercise don't have the same level of evidence that statins do. Once you get to a certain point, if you've had a heart attack, you got to be on a statin. So which statin? Simvastatin, atorvastatin, or rosuvastatin generally have the best evidence of the highest potency statin. We may see genetic testing in the future, but it's not really out yet. Lots of media stuff about statins, and I feel like I always read these things. Are statins really as good as they want? Are they really any problem? Well, you get these examples of people who maybe shouldn't have been on a statin or had resistance to statins, and yes, they don't work for everyone, but overall the evidence is absolutely overwhelming that they have a tremendous impact on health of patients. So in fact, in the UK and maybe some other European countries, you can get simvastatin over the counter, which I wouldn't advocate for personally, but that's how they think it's benign enough where you could do that. Other cholesterol agents, I'm not going to spend a lot of time on these. In fact, I'm going to go through them very quickly. Fibrates are used to lower triglycerides. The only time you would do these is if your triglycerides are really high. The reason being is your triglycerides are really high. You can't measure other cholesterol. Cholesterol is a calculation. So LDL is calculated based on total cholesterol minus HDL minus trigs divided by 2.2. Meaning if your triglycerides get so high, you can't calculate an accurate LDL. Meaning you can't really check to see if somebody's at that 190 cutoff or not. So in that case, we'd start a fibrate on somebody and try and lower that with one of these drugs. Fibrates are gemfibrozil or fenofibrate. They're essentially interchangeable. There's not a big advantage over one or the other. There's some different side effects. Gemfibrozil is contraindicated with renal dysfunction. Fenofibrate's not. It's the biggest difference there. Niacin's a vitamin B drug, which you can get over the counter. There's a couple different branded products of it too. There's slow niacin, which is a slow release product. So Niaspan, which is a prescription product, meaning it's actually FDA approved for specific treatment. And also you actually know what you're getting. Whereas if you buy a vitamin B supplement over the counter, there's no regulatory body that has any authority to make sure that that is indeed vitamin B3. The prescription product would be validated in that way. It's an old lipid-lowering drug. It's the best drug we have on the market that raises HDL. It does cause flushing, which is probably its biggest side effect. Also causes myalgia. So with high-dose statins, we don't combine that with niacin. Bile acid resins cause they prevent cholesterol from being absorbed from the GI tract. They're not systemically absorbed, so they don't have side effects that way, but they do have to be taken 2 to 4 times a day. They may cause malabsorption of various vitamins too. They're okay to use in pregnancy, so this might be an alternative. It's really probably the only alternative to a statin. So if you do have a pregnant patient, you're really concerned about their cholesterol, you might consider one of these drugs. Ezetimibe, Zetia. It's an oral drug that causes decreased uptake of cholesterol in the small intestine. It was used a lot as a product called Vytorin when simvastatin did a lot of studies to look at it. However, there's one big trial called the ENHANCE trial that looked at combining, checking if somebody's outcomes with simvastatin versus simvastatin plus ezetimibe. It showed that there wasn't any advantage to that. Even though there was an additional 15 to 20% LDL lowering, there wasn't any mortality benefit outcomes, interestingly enough. However, a new trial called Improve It just came out very recently that revisited some of the long-term data with this process with this idea of simvastatin plus ezetimibe, and actually showed benefit with the combination from a mortality standpoint. So the jury's still out on whether it's a good drug or not, but it is something that could cause additional LDL lowering. Pretty rare side effects overall. It's not generic, so it is sort of an expensive option. And the benefits, again, are questionable, if not minimal, so we don't really know for sure. There needs to be some more evidence to really say, because both those trials were big and well done. I don't really know which one's the better one to go with at this point. These ones, I'm not going to spend a ton of time on them. If you're really interested in PCSK9s, you can read about them on your own. They're very new, and the only reason I probably put them in here is because it's interesting to talk about. These are monoclonal antibody drugs. What they do is they work with the liver enzyme that leads to an LDL receptor degradation, and they prevent that LDL receptor from degrading. What they do is they're very potent at LDL reduction. In fact, they're much more potent than statins. Up to 60%, 70% is monotherapy, and as statin adjuncts, they can add on an additional 60% LDL reduction, which is pretty big. So where these drugs are going to be used are going to be for familial hypercholesterolemia. People who have a family history of high cholesterol are traditionally very resistant to being able, or not personally resistant, but their bodies are resistant to responding to statins. People who are intolerant to statins, maybe people who get really bad myalgia with every statin they've tried, or really high-risk patients potentially. The biggest question mark with these drugs is, are they going to be used because they're so expensive? And if you applied them to everyone who needs a statin right now, you'd end up with an insane amount of healthcare expenditures associated with these medications. So we don't know where they're going to be used, but they are approved now. We're going to see them kind of fit into therapy in different areas. So it'll be interesting to see how these end up being used in the long run. Here's some clinical evidence in case you're curious of the different products. I talked about the controversy. The other thing I'll mention too is sometimes in these clinical trials they looked at with these drugs, the LDLs were lowered much lower than what you'd see as a normal healthy person. So if you took somebody who doesn't have any cholesterol or cardio history, maybe you took like a 20-year-old who's very healthy and active and doesn't have any medical history or family history, their LDL is probably going to be 60 to 70 to 80, maybe something like that normally. So it's not going to be super low. It's not like you can get your LDL really low. Your body needs some LDL to transport cholesterol. Cholesterol is essential for a lot of different functions in the body. So the question with this is, if we're obliterating people's LDL, does that cause long-term problems? And no one really knows. In fact, one of the big side effects that they're watching is a neurocognitive deficit that's been seen to be slightly higher with these medications than with anything else. Now, it's still quite rare, but it is something that's been seen. Also, upper respiratory tract infections have been seen with these medications. Who knows why? So anyway, some side effects to watch out for, but they are kind of interesting. And if you are interested in learning more about them, because they are monoclonal antibodies, they could potentially be seen as a use for pregnant patients who need control of LDL during a pregnancy, because they likely probably don't have a lot of systemic side effects, because monoclonal antibodies usually don't cross the placenta. It's possible they might, but highly unlikely. So again, they could find a role maybe in that patient population. It'd be difficult to say for sure, but you never know. Okay, primary versus secondary prevention. You don't need to force a statin for a primary thing, but you want to take all your risk factors into consideration, check your LDLs, and make sure you're offering something to patients. Remember, the evidence is pretty overwhelming for these drugs. If you don't at least talk to your patient about them, that's something you definitely want to consider. Secondary prevention, statins are going to be required for certain things. So post-ACS, post-stroke, going to be required to be on a statin. Here's an algorithm quickly, which I think we've gone over. And that's all I've got for you guys today. So thanks very much for listening. And again, questions, send me an email or post on the forum. Thanks, guys.